There are over 20 disease-modifying therapies for multiple sclerosis, but which one is the best? Which one is the most effective? How do they compare to each other? Now, I could speculate based on my experience or indirect comparisons from different clinical trials, but today we're going to look at actual randomized head-to-head trials of different multiple sclerosis medications and see which one is the best. And at the end, I will give you a list of medications ranging from best to worst. We're not going to talk about side effects. We're not going to talk about boring details of inclusion criteria or intricacies of the studies. We're going to look very quickly at the key results from virtually all of the randomized head-to-head trials done in multiple sclerosis, mostly class 1 randomized controlled trials. Let's have some fun. Now, I'm not going to talk about inclusion criteria in the individual trials, but suffice it to say, these are randomized trials in relapsing multiple sclerosis, and a lot of them had inclusion criteria requiring a certain age or disability level or absence of certain comorbidities, so you'll have to look into the individual trials if you want to know the exact data. I can't include everything in the show notes, but I'll try to include some of the major references, and if you want me to give you a specific references, please post in the comments and I'll go ahead and give you the link. If you want to skip ahead to the comparison that interests you most, I'll go ahead and put up those comparisons and the timestamp so you can go ahead and skip ahead. And by the way, I would encourage you to try to make decisions about your own care with your trusted provider rather than from a YouTube video. I intend this only for general information, but hopefully it's useful to you, and if you could go ahead and click like to make the YouTube algorithm show this video to more people, I would greatly appreciate that, as I spent a lot of time and effort putting together this information. By the way, I'm Brandon Bieber, and I make videos about multiple sclerosis every Wednesday, so please subscribe and ring the bell for notifications. Let's start with the evidence trial from 2002. This is a study comparing two formulations of the exact same medication, beta interferon 1A. So Rebif is beta interferon 1A 3 times a week, and Avonex is beta interferon 1A intramuscularly once a week. And they're both the exact same medication made from hamster ovary cells. And you can see, looking at the cumulative probability of patients experiencing a new relapse, less of them, the solid line, experienced a relapse on Rebif than on Avonex. So Rebif, high-dose, high-frequency interferon, is less well tolerated because you have to take it more often, but it seems to be more effective in preventing relapses. You can see something similar looking at MRI results. This is the average number of combined unique lesions, which includes gadolinium-enhancing lesions, new T2 lesions, and enlarging T2 lesions. And you can see that those taking Rebif had about half the number of new lesions. Rebif is the dark boxes, Avonex is the unfilled boxes. And you can also look at a similar study comparing Betaseron versus Avonex. Betaseron is beta interferon 1B, subcutaneous every other day. And against Avonex is beta interferon 1A, intramuscular once weekly. And looking at the proportion who were relapse-free, those who were taking the high-dose, high-frequency interferon, in other words, Betaseron, definitely did somewhat better. And you can see the proportion of individuals who did not have new T2 lesions showed essentially the same thing. Betaseron was more effective than Avonex. Now, this is another study looking at two different doses of Rebif. Again, Rebif is beta interferon 1A, subcutaneous 3 times a week, and they looked at 22 micrograms versus 44 micrograms. And there really wasn't any statistically significant difference. But if you look at the two columns, 22 micrograms and 44, you can see there's sort of a trend towards superiority of the 44 microgram dose, and that's why that is the currently clinically used dose. So the summary of all of these studies is that basically giving more interferon seems to be better than giving less interferon. Now, this is a study looking at glatiramer acetate Copaxone, which is similar to the new formulation Glatopa, versus Avonex. Now, historically, doctors used to think that glatiramer acetate was sort of worse than the interferons. And the interferons, even though maybe they had more side effects, flu-like symptoms and things like that, were a little bit more effective. Now, this study was really designed to see if you could combine the two agents, if you could add glatiramer acetate plus interferon and make it more effective than just one of the agents alone. And it actually did not show that, because if you look at the comparison of the green boxes, glatiramer acetate, versus the combination, the blue boxes, there was absolutely no difference whatsoever. However, this study accidentally showed that glatiramer acetate seems to be better than Avonex, which is the low-dose, low-frequency interferon, not the other interferon formulations. But here, glatiramer acetate seems to prevent relapses a little bit better. And by the way, PDE stands for protocol-derived exacerbations, and NPDE describes non-protocol-derived exacerbations, but it doesn't matter. The data are essentially the same, with glatiramer acetate actually being a little bit better than Avonex at preventing relapses. And this is looking at 6-month disability progression, and there was no statistically significant difference, but you can see that glatiramer acetate has a trend towards superiority over interferon, and combining the two agents did absolutely nothing, which is why we don't combine these agents. Now, what about other injectable trials? Well, Copaxone versus Betaseron showed that they're approximately equal in the Beyond trial. But in the Regard trial, Rebif versus Copaxone, and by the way, this is the 44 microgram dose versus Copaxone, there was no difference in relapse rate, but there were fewer gadolinium-positive lesions in the Rebif group. So perhaps high-dose, high-frequency interferons, such as Rebif, or by extension Xtavia and Betaseron, may be a little bit better than Copaxone glatiramer acetate. Now let's look at the oral agent Gilenya, the first oral agent to be FDA approved for multiple sclerosis. This is the Transform study, one of the pivotal trials leading to the FDA approval of Gilenya. And they actually used two different doses of Gilenya, 0.5 milligrams and 1.25 milligrams daily. 0.5 milligrams ended up being the dose that's clinically used. And they compared it to Avonex, which is beta interferon 1A intramuscular weekly. And you can see that fingolimod, 0.5 milligrams, was better than Avonex, decreasing the number of relapses by about 50%. So 0.33 relapses per year on average with Avonex versus 0.16 relapses per year with Gilenya. If you look at the MRI outcomes, it's a similar story. So looking at the three columns, we're looking at Gilenya 1.25 milligrams on the left, then 0.5 milligrams in the middle, and then Avonex on the right-hand side. And if you look, for instance, at the average number of enhancing lesions, it was 0.23 in the Gilenya 0.5 milligram group versus 0.51 in the Avonex group. So greater than 50% reduction versus Avonex, not versus placebo. So that was pretty impressive. And both doses beat Avonex on all MRI outcomes. And now if you look at disability, it's a little bit less impressive because there wasn't a lot of change in disability overall. But the 1.25 milligram dose did achieve statistical significance over Avonex. Although there's a trend towards superiority of the 0.5 milligram dose, it wasn't actually statistically significantly better than Avonex. And again, these are very, very small differences. Now, what about another S1P receptor modulator? This is a new medication, ozanimod or Zeposia. Now, again, all these medications are very similar. Mayzent or siponimod, ozanimod, and fingolimod, which is Gilenya. They're all very similar. But you can see very similar data in the Sunbeam trial, which is relatively recent, 2019. I just included it here because it's so similar to Gilenya. And you can see, looking at the relapse rate, it was much better in ozanimod versus Avonex. And you can see, roughly 50% reduction in relapses, again, compared to Avonex. Now, what about another oral medication? This is Tecfidera dimethyl fumarate versus Copaxone in the Confirm trial. And the actual FDA-approved dose for Tecfidera is twice daily. So you can sort of look at that blue bar, and you can see on average there were 0.22 relapses per year. And in the glatiramer acetate or Copaxone group, there was a 0.29 rate of relapses. So Tecfidera was a little bit better, but this was not a statistically significant difference. However, if you look at the MRI activity, there were fewer new T2 lesions in the Tecfidera group compared to glatiramer acetate. So 5.1 versus 8 in glatiramer acetate. And this was statistically significantly different. Now, I will mention that although this was sort of a class 1 trial, it wasn't really a double-blind, double-dummy trial. In other words, the people who got randomized to the pills, either placebo or Tecfidera, they weren't doing placebo shots, so they weren't injecting themselves with saline daily. And they did this just so they could recruit people in the trial, because it's very hard to randomize people to getting a placebo injection every day. So this could have biased the trial a little bit, but there does seem to be some superiority of Tecfidera over glatiramer acetate. Now, this is another oral medication, Aubagio or teriflunomide, and they studied 2 different doses, 7 milligrams and 14 milligrams, both of which are actually FDA and EMA approved. And they compared it to Rebif, which is interferon beta 1A 3 times a week, so one of the high-dose, high-frequency interferons. And for whatever reason, the primary outcome they used was failure of the medication, defined either as a relapse or a discontinuation of the drug. And they found that if you look at the 14 milligram dose, it was about the same as Rebif. However, if you look at the 7 milligram dose, it was actually inferior. And in another study, teriflunomide 7 milligrams defeated placebo. So teriflunomide, or Aubagio 7 milligrams, is effective to some extent, but not as effective as the 14 milligram dose and not as effective as Rebif. Now, this is a medication that's somewhat older and is not actually FDA approved for multiple sclerosis, which is Imuran, or azathioprine. This is actually a purine synthesis inhibitor, so if I were to compare it to another oral medication for MS, the best comparison would perhaps be to Aubagio, which is a pyrimidine synthesis inhibitor. Now, in this study, very unusual study, they used an extremely low dose, only 50 milligrams daily. And they did it as an add-on trial to Avonex. So there were multiple groups, so Imuran plus Avonex, or Avonex alone, or Imuran plus Avonex plus steroids. And looking at this study, there's really no statistically significant difference with anything, but there's a slight trend towards adding Imuran and a slight trend towards favoring adding prednisone, but nothing really impressive here. And long-term prednisone is not really a great treatment for multiple sclerosis, just because the risk of side effects is quite significant. Now, the more typical dose of Imuran would be about 2 to 3 milligrams per kilogram per day, which, depending on your weight, could be something between 150 milligrams a day to 300 milligrams a day. So I wouldn't make too much about this particular study. Some other studies have shown that Imuran, or azathioprine, and interferons actually favor azathioprine, perhaps, or demonstrating that azathioprine is about equal or non-inferior, but some with a non-significant trend favoring superiority of Imuran. Now, I'll tell you that I got this from a poster that was shown at a conference, not from actual published data, so take it with a grain of salt. Now, this is a study of Tysabri, perhaps the first modern high-efficacy disease-modifying therapy. This is the Sentinel trial comparing Tysabri to Avonex. Now, for whatever reason, they actually added Tysabri to Avonex versus Avonex alone. So it was a very strange study where people were actually taking 2 medications. However, I would presume that in patients taking Tysabri, the Avonex wasn't really doing anything, so you can really attribute all the difference essentially to the Tysabri. And you can see, if you compare the combination group on the left-hand column, the average number of relapses was 0.34 compared to 0.75 in the interferon beta 1A or Avonex only group. So Tysabri was definitely superior. And you can see similar results from the MRI studies. And it's a kind of a busy slide, but if you direct your attention towards the bottom, where you're looking at number of gadolinium enhancing lesions, you can see that the combination group with Tysabri only had an average of 0.1 enhancing lesions versus 0.9 in the Avonex group. So in other words, a 90% reduction with Tysabri. Very impressive data. Now, this is the data on disability progression from the same study, and you can see that those who got Tysabri had less disability progression versus Avonex alone. Now, this may not look very impressive to you, but it's very difficult to show a difference in disability progression over a short period of time, just because a lot of people don't progress even if they're on a low efficacy agent over a short period of time, or even if they're taking nothing. So it's really difficult to show a difference in disability progression. And generally speaking, in MS clinical trials overall, it's easiest to show a difference in new lesions. intermediately difficult to show a difference in relapses, and most difficult to show a difference in disability progression. So even though this may not look very impressive, it was statistically significant and it is clinically meaningful. Now let's look at another interesting study looking at the combination of Rebif, a high-dose, high-frequency interferon, with steroids. So this is Rebif alone versus Rebif with methylprednisolone, oral methylprednisolone, similar to Solumedrol. And they gave 500 milligrams daily for 3 days a month, so a total of 1,500 milligrams a month. So a pretty significant dose. And basically, they found absolutely nothing. Adding steroids to Rebif didn't do anything for disability progression. However, another study called the Norman study, they also looked at Rebif, but this time they tried methylprednisolone 200 milligrams daily for 5 days once a month. So actually a little bit of a lower dose, only 1,000 milligrams a month. And they actually found that the relapse rate in the combination group decreased by 62%. So maybe adding steroids does do something. Now, this is not a treatment I would personally use. I think that the side effects of steroids are likely too deleterious to warrant its routine use as a preventative, but you have to say this is a positive result. Now, what about Laquinimod? Now, Laquinimod is not actually an FDA or EMA-approved disease-modifying therapy for MS, and you'll soon see why. This study, the Bravo study, looked at Avonex, which again is probably one of the least effective disease-modifying therapies for multiple sclerosis, against Laquinimod. And there was no real statistically significant difference, but there was a non-significant trend towards superiority of Avonex over Laquinimod. Again, to lose to Avonex is not very good. Also, Laquinimod failed to demonstrate any benefit in disability progression versus placebo, or changes in another disability profile called the MS functional composite, which is actually better than EDSS in measuring disability. So not very impressive data for Laquinimod. Now, what about bone marrow transplant, hematopoietic stem cell transplant? If you're not familiar with this treatment, hematopoietic stem cell transplant is essentially a rebooting of the immune system. Very strong, powerful chemotherapy drugs are given to wipe out the immune system. And then a bone marrow transplant, or another form of hematopoietic stem cell transplant, is performed to sort of reboot the immune system. Now, it's believed that it's actually the drugs that have the effect on multiple sclerosis, and the so-called stem cells are not really to grow nerve tissue, but rather just to sort of replenish your red blood cells and replenish your immune system to decrease the risk of side effects. And there are all kinds of regimens used. So this was the ASTIM study, which is a European trial published in 2015. And one of the things that's impressive about this study is they compared hematopoietic stem cell transplant against Novantrone, or mitoxantrone. Novantrone is an older multiple sclerosis disease-modifying therapy which is highly effective. It's no longer used in MS today just because of the side effect profile. It can cause heart failure and even a rare side effect of leukemia known as promyelocytic leukemia. So it's not really used in multiple sclerosis at all, but it is a highly effective agent. Now, in this study, and this was multiple different European centers, they used different regimens, but they used drugs such as Cytoxan, carmustine, antithymocyte globulin, basically powerful immunosuppressive agents. And they followed the patients for 4 years. Now, one thing that I should mention is Novantrone was only given monthly for 6 months, and Novantrone isn't necessarily the kind of induction treatment that you can only give for 6 months. So arguably, it's not really a fair comparison. But that being said, hematopoietic stem cell transplant won easily, reducing new lesions relative to Novantrone by 79%. Also, better outcomes in terms of enhancing lesions and relapses, although there was no difference in disability progression, so it didn't hit that marker. This was a more recent study published in 2019. The first author of this study is Dr. Richard Burt, who's a hematologist well known at Northwestern for using hematopoietic stem cell transplant to treat autoimmune disease. And he's actually supposedly the doctor who treated the celebrity Selma Blair, who reported that she had aggressive relapsing MS. And this was an unusual study in that it was randomized, but it was sort of randomized against various different disease-modifying therapies, which were apparently the choice of the neurologist. So when entering the study, the patient would either be randomized to get the bone marrow transplant or another disease-modifying therapy at the discretion of the neurologist. And they were supposed to change disease-modifying therapies to a drug that was more potent or in a different class. Now, the problem here is that I would be interested in comparing hematopoietic stem cell transplant against other high-efficacy agents. It just doesn't make sense to compare a bone marrow transplant against Copaxone or against interferon. But the reality is that a lot of the patients were really on injectable medications or oral medications, and very few were on high-efficacy medications such as Tysabri. And in fact, there were no patients on Ocrevus or Lemtrada entered into this study. So it's not exactly a fair comparison. That being said, hematopoietic stem cell transplant won easily. What you're looking at is the percentage of patients with disability progression, and you can see almost none who got the bone marrow transplant progressed, less than 20%, whereas a significant proportion of those on routine disease-modifying therapies did progress. So this is an overwhelming favorability of the bone marrow transplant. Looking at relapses, it's much the same story. This is time to first relapse. You can see less than 20% had any relapses on bone marrow transplant, but a significant percentage who got the standard disease-modifying therapies did. Again, a lot of these were low-efficacy agents, so it's not exactly a reasonable comparison, but I have to say, hematopoietic stem cell transplant won by a very large margin. What about another high-efficacy agent? This is Lemtrada, alemtuzumab, from the CARE-MS2 study. Now, they used both a 12 milligram dose and a 24 milligram dose, but we'll just look at the 12 milligram dose. And you can see, looking at relapse-free survival, the proportion of people who did not have a relapse throughout the study was much greater in those who received Lemtrada. And I should mention that Lemtrada was compared against Rebif, which is a high-dose, high-frequency interferon, which we previously saw is more effective than a medication such as Avonex. We can see the same story with sustained disability. Again, the blue line is the proportion who developed worsening disability on Lemtrada versus the red line in those who received Rebif. And again, it's relatively difficult to show a big difference in disability over a short period of time. This was only 2 years. However, in the MRI outcomes, I didn't find this to be that impressive. Certainly, there were far fewer enhancing lesions and newer enlarging T2 lesions in people getting Lemtrada, but this was actually somewhat less impressive than what we saw with Tysabri versus Avonex. So perhaps in disability data and relapse data, it was pretty impressive, but in terms of MRI outcomes, maybe not as impressive. Now, what about methotrexate? Again, this is an older anti-metabolite agent, perhaps most similar to Aubagio. And it's not really routinely used in multiple sclerosis, though it has been studied in multiple sclerosis. So one old 1993 class 3 study, so a relatively low quality study, versus placebo, showed that it did absolutely nothing on the risk of relapses. However, one class 2 study compared methotrexate to beta interferon, and the difference seemed to favor Avonex slightly. So there was a sort of non-statistically significant trend favoring Avonex. So it's really unclear if methotrexate works at all, and if it does work, it may actually be less effective than Avonex, which is, again, probably the least effective approved disease-modifying therapy. What about Ocrevus? Now, currently, Ocrevus, ocrelizumab, is the most popular disease-modifying therapy in the United States. And I actually participated in this clinical trial, in the OPERA trial, comparing Ocrevus versus Rebif, which was the trial in relapsing multiple sclerosis. And there were actually 2 different trials, and we're looking at both OPERA 1 and OPERA 2. And you can see, if you look at the rate of relapses, the data are exactly the same in both trials. For instance, in OPERA 1, the rate of relapses was 0.16 relapses per year on average with Ocrevus, versus 0.29 relapses per year with Rebif. So this definitely favored Ocrevus, definitely more effective. We could also look at confirmed disability progression, and you can see that less people had worsening disability taking Ocrevus than people who were taking Rebif. Now, it was really difficult to show a difference here because only 12.0% of people had worsening disability in the Rebif group, compared to 7.6% in the Ocrevus group. And by the way, the little inset there is essentially just a zoomed in version of the greater chart. Now, what about another oral MS disease-modifying therapy. This is cladribine, which was compared against various formulations of interferon beta. So it's sort of a weird study. So this is kind of a combination of high-dose, high-frequency beta interferons such as Rebif or Xtavia or Betaseron, but also some of these individuals were taking drugs like Avonex. So it's sort of a weird comparison. But regardless, cladribine was much more effective. You can see, looking at the annualized relapse rate, only an average of 0.12 relapses per year versus 0.32 on the interferon beta formulations. You'll note that this difference is greater than the difference between Gilenya and Avonex and the Transforms trial, and some of these patients were on agents that were superior to Avonex. So you have to say, looking at an indirect comparison, cladribine is likely more effective than Gilenya. Now, this is an unpublished study, the Asclepios trial. There are two trials, Asclepios 1 and 2. Now, these studies have not actually been published. You can see what I have here is a screenshot of a photo taken by Dr. Barry Singer, who's a multiple sclerosis neurologist who's active on Twitter and has a really good multiple sclerosis podcast you should definitely check out. But just take this with a grain of salt because it's completely unpublished, unreviewed. This was presented at a professional conference. Ofatumumab is a medication very similar to Ocrevus and Rituxan. It's a B-cell depleting anti-CD20 agent. It's a little bit different in that it's a subcutaneous or under-the-skin formulation, but it essentially has the same efficacy, we believe, and similar side effects. These studies were incredibly effective. So Asclepios compared ofatumumab against Aubagio, teriflunomide. So Aubagio, from the prior data I showed, is probably fairly similar to Rebif in terms of efficacy, at least the 14 milligram dose. But you can see that even compared to Aubagio, ofatumumab reduced relapses by 50 to 58%, depending on which of the two trials you're looking at. So pretty impressive difference against an active comparator. If you look at the MRI data, it's just incredible. This is looking at the reduction of enhancing lesions versus Aubagio. And you can see in one study it decreased enhancing lesions by 97.5% and Asclepios 2 by 93.8%. So incredibly effective at suppressing active lesions. And again, this is not against placebo. This is against another agent that already has some activity in suppressing active lesions. So very, very impressive data here. And this is looking at disability progression, and you can see both looking at, this is pooled analysis between the two trials, looking at both 3-month disability progression and 6-month disability progression. It reduced disability progression by about a third, very similar to some of the other studies we looked at, such as OPERA for Ocrevus, and also for the other high efficacy agents such as Lemtrada. Okay, let's look at the overall rankings. Now, I admit to you that there's some amount of speculation on my part, but I have to say hematopoietic stem cell transplant is likely the most efficacious treatment. The reason I say this is because it looked favorable against another high efficacy treatment, Novantrone. No other medication can make that claim. I can't say for sure that Lemtrada or Rituxan or Ocrevus or Tysabri wouldn't be as impressive against another high efficacy medication, but they simply have not shown that. Also, I have to rank it tops because it has the potential to generate long-term remission. Now, as I showed in the studies, it's not like no one receiving this treatment progresses or no one receiving this treatment has a relapse, but certainly a pretty significant proportion of people have no relapses and no disability progression even years after the treatment has been given. And so you have to give this type of induction therapy that doesn't require recurrent treatment an advantage. Number 2, I would rank Lemtrada or alemtuzumab. Now, I wouldn't say the data is necessarily any better for Lemtrada. If I look at the CARE-MS2 study versus, say, the OPERA study or the recent Asclepios trial, I can't really say that Lemtrada defeated Rebif by any kind of overwhelming margin. But the reason I have to rank it above some of the other agents is just because there's the potential for long-term remission. The advantage here is that you give the treatment once and then again the next year, and then you don't necessarily have to redose unless there's a return of disease activity. That in itself represents superior efficacy, I would argue. Now, the same may be true for drugs like Novantrone or Ocrevus or Rituxan, but it hasn't been, or even cladribine, but it hasn't been definitively proven. So that's why I would rank this number 2. Number 3, I would put several different high-efficacy medications. Novantrone, it's very difficult to compare to the other agents because it was really only studied against hematopoietic stem cell transplant and in a very unfair way. So I'm just sort of speculating that it belongs in this category. I would include it in the same category with 3 B-cell depleting agents: Ocrevus, Ofatumumab, and rituximab, which is Rituxan or Truxima. And there's really no data to suggest that one of these agents would be better than any other agent, at least not convincing data in my opinion. Cladribine, I would say, defeated the interferons by a sort of comparable amount as Ocrevus, so I would put it in the same category, although there's no head-to-head comparison. And same with Tysabri, very impressive data versus Avonex, especially in terms of MRI outcomes. So roughly speaking, I would put them all in the same category in the absence of further data. Now, in the next category, I would put the S1P phosphate receptor modulators, such as Gilenya, fingolimod, Mayzent, siponimod, and the most recent ozanimod. All these medications are very similar, demonstrating superiority against Avonex, or at least Gilenya and ozanimod have demonstrated that superiority. And by indirect comparisons, they're likely superior to other medications such as high-dose, high-frequency interferons. In the next category, I would put a very unusual combination of high-dose, high-frequency interferon plus oral methylprednisolone. And this is just based on that one study suggesting that that combination may be favorable in suppressing relapses. Again, long-term methylprednisolone is not something that I would favor just because of the potential side effect profile, but you can't really argue with that one study. It does seem to increase efficacy somewhat. In the next category, I would put a lot of different medications. One is the high-dose, high-frequency interferons, such as Rebif, Xtavia, Betaseron, and then also a few of the oral medications. So Aubagio in an actual head-to-head trial versus Rebif was approximately equal, so it definitely belongs in this category, at least the higher dose, the 14 milligram dose. Imuran, based on some low-quality studies, is not very effective at a low dose, but is probably moderately effective in comparison to the high-dose, high-frequency interferons at a higher dose. And I wrote 150 milligrams here, but really I mean 2 to 3 milligrams per kilogram per day. I also included Tecfidera here, just because there's sort of a trend towards superiority over glatiramer acetate, which is the next category. And there was a statistical significant difference in terms of MRI outcomes, but not a statistically significant difference in terms of relapses. And I put the high-dose, high-frequency interferons over glatiramer just because of the one study showing superior MRI data of Rebif versus Copaxone. So the next category, of course, is glatiramer acetate, which is Copaxone versus Glatopa. And I put those medications over Avonex based on the COMBI-RX study, which sort of accidentally showed that glatiramer is better than low-dose, low-frequency interferon. Now, Aubagio's 7 milligrams is really difficult to rank. We definitely know that it's inferior to high-dose, high-frequency interferon based on comparison to Rebif. I could have put it in category 7, but I chose sort of arbitrarily to go ahead and place it with Avonex in category 8. The next category is drugs that likely have some benefit in multiple sclerosis, but marginal benefit and likely inferior to Avonex. So this includes low-dose azathioprine, such as 50 milligrams per day, or Laquinimod, based on the Bravo study I showed earlier. Now, category 10 is medications that are likely ineffective, or at least unproven. So I included placebo, but also methotrexate, which really failed to beat placebo. There's no real convincing evidence, in my opinion, that long-term monthly steroids are beneficial in multiple sclerosis. Even though this was a popular treatment at one time, I can't really find any significant trial suggesting there's a benefit in the long term. Also, intravenous immunoglobulin, even though it's used by some neurologists, the data is largely negative in actual randomized studies, so I have to put it in this category. Now, what could be worse than placebo? Well, there are certain drugs that actually have been shown to worsen multiple sclerosis. One example is the TNF-alpha blockers, such as Humira, used to treat rheumatoid arthritis and psoriasis. We used to think that multiple sclerosis was sort of like psoriasis of the brain or rheumatoid arthritis of the brain. But it turns out that different immunological mechanisms are driving these diseases. And it's reported that medications such as Humira may make multiple sclerosis worse or may even cause multiple sclerosis and should be avoided. Also, there's older evidence suggesting that interferon gamma, which is used to treat certain immunodeficiencies, can actually worsen multiple sclerosis, again, based on very old data. I hope you enjoyed the presentation. If you would like to see a specific reference, please post in the comments below. If you have any general questions or suggestions for future videos, please post in the comments below.